buddy?
What up?
Welcome back to Unboxing Performance. I am co-host Vito, and we got co-host Vince.
What's up, y'all?
Today we're just going over BFR. So our first episode was actually my narrative review, one of the topics I'm pretty interested in. Today, discussing BFR is actually Vince's narrative review. So we'll lean on him a little bit for some of the more particulars, but our goal is just kind of define what is it, what's it being used for, how can we use it in our practice, and call it after that. Sound good?
Let's do it.
Cool. So BFR in general, what it is utilizing occlusion combined with exercise. And what that does, so you're occluding typically either upper extremity or lower extremity. It can be bilateral, it can be unilateral, creating some sort of force that restricts blood flow restriction. And you combine that with exercise, it creates hypoxic muscular environments, meaning less blood flow, less oxygen. And so I'll just go and ask my question and pose it to you. So I was reading through some of the physiology or what we think it is. And in general, the goal of BFR is to induce some sort of strength or hypertrophy. And what we get with high intensity or high volume, high load hypertrophy training is lactic acid buildup. And then the existence of that lactic acid stimulates some sort of enzymatic cascade for human growth hormone. And I mean, so in general, what's happening with BFR is that because there's a decreased blood flow, there's decreased O2, so it's greater anaerobic training when you have BFR. So even though it's low intensity, you're still getting that same hypoxic environment that's causing that HGH influx. That what I was getting from those papers.
Yeah, essentially. So I feel like that's putting it very roughly, essentially. So to put it even more simple, it's the body's response to essentially an external trauma. And the way I kind of explain it to people in terms of like how it works is that this external pressure is basically causing a vasoconstriction of all like arteries and different things running through the leg. Generally, it's used in the legs. And this external trauma going over a period of time sends signals to the body that something's really not right. And we need to increase what nutrition and what vital things and components that we're already sending there. So essentially send signals to the brain like, hey, we're having a hard time getting nutrients over here. We need to up it to give it more. And I was talking to Mark about it not too long ago, and he was saying that this also has a greater systemic influence on the lower extremity and even can cause increased HGH and other hormones to cascade into the other side, the uninvolved extremity that we're working with also. And we also can see benefits from that side. So this can be applicable for a lot of reasons, but in general, we're using that hypoxic environment to promote increased blood flow post treatment session with us. And we're looking at a lower intensity in terms of loading, but greater intensity in terms of lack of oxygen to the area during. And then once we go post, we see an increased flow of blood to that area because of the external forces we have now learned to apply.
Kind of like EPOC with high intensity cardiovascular.
Exactly. Gotcha. So just a new fun way essentially of treating it. Plus it is safer than a lot of people I think give it credit for, and it's better than trying to load someone post-op as quickly as we'd like.
I think that's actually a good pivot point, the safety of it. Safety is really helpful when you have a pneumatic device that is measuring your level of occlusion and then you're able to set
Right.
standards on it. But that's not the only type of BFR. There are other types. You can use bands, you can use straps. However, there's no way to measure the level of occlusion that you're getting when you're using bands or straps. So if you're a lifter, an athlete who's doing it on your own, you can do it on your own, but there is a level of uncertainty when you apply BFR training without a pneumatic occlusion device and without someone monitoring you. You definitely want to be measuring blood pressure before, after, and everyone, and notice how your body responds to it if you've never done it before. So just a safety point with that.
Yeah. I agree. The pneumatics are definitely the best way to go. I had heard someone talking about BFR not too long ago, mentioning how the gym culture and stuff had been using bands and straps well before therapy and PT had decided to take an interest at it. And I think that can kind of attest to there's some things that gym culture kind of learns about and kind of runs with it. And then finally we decided to take heed and make it a little more scientific. So I agree. I wouldn't recommend using straps or bands in the gym if you're not well aware of what you're doing and making sure it's safe. If you have the pneumatic cuffs, that'd be really fancy to see at a public gym or something like that.
All right. Well, let's go into some of the research. Since we are using it, we are studying the science behind it, getting some physiology theory. It is your narrative review. I read a couple of the systematic reviews you sent over and a couple of the articles. I looked at the one comparing ACL and knee OA too, which I thought was cool. In general, what did you guys come up with as your narrative review on all the BFR articles you guys read? What were some of the big points you got out of it?
So some major things we saw is it works, essentially. I think we had about 18 articles that we looked at, and all studying different modes of dosing and limb occlusion pressures that will benefit someone. Generally, the patient populations were all post-op, post-surgery and stuff like that, either fractures that were ORIF or ACL ligamentous injuries. And a lot of what we saw were that we had a lot of increased cross-sectional area in the musculature surrounding the joint. We had a lot of increased strength, and then a lot of increased functionality and decreased pain. So a lot of things we tried to tie in to make them all kind of cohesive as a unit was figuring out what exactly were meaningful changes for each of the articles that we looked at. And we basically ran it down to increased performance, that being cross-sectional area, strength, and range of motion. Those were, I would say, the big three in terms of what we saw. We saw a couple others in terms of like a bone density scan and like DEXA scanning, but those didn't have as much research behind it. But overall, I think one of the things that the research is not really putting forth is a consistent limb occlusion pressure and dosage for BFR. So we saw wide variety, anywhere from 130 milligrams per mercury to 180 of occlusion. And then we had some research articles that even cascaded. So they went from a high to low of pressure. So they started integrating increased percentage of occlusion as they went further into programming. And we also saw a couple things of their timelines. So a lot of the research didn't have much consistency, and this is kind of where we're getting at for future research during our narrative review, is to set a good timeline for patients post-op to start using BFR. I believe the soonest we had in terms of patient populations using BFR was two to 3 days post-op. So that was the earliest we saw. And ironically enough, in that 2-day post-op, we did see some decent results in terms of decreasing pain to the area, which obviously decreasing pain is super beneficial for any patient. It's just going to give them a lot more room to work. And I believe moving forward, as like research becomes more available for us, having those more consistent guidelines is going to help promote this as a therapy tool a long way in the future. And yeah, that's all I really have to say. If you have more questions about it, Vito, let me know.
Actually, I was going to ask, because I couldn't remember if I gleaned this or not, but I feel like there's an allusion to the occlusion itself without exercise could still generate some systemic effects. Is that something that you guys found at all? Because I could have read into it a little bit wrong too, and or just not understood what the abstract was saying. But is it occlusion with exercise? Obviously, you're gonna get the greatest effect, but is there any benefit to just having timed occlusion on pain or quality life, or is that something that maybe needs to be researched or considered?
That is something to consider. I didn't read any articles or come across any articles that just focused on sheer occlusion. I think it's more because of the idea of we can occlude it, let's capitalize. And I think one of the big promoters of BFR is the fact that you can push the patient more than you typically would because of the low load that it involves.
Mm-hmm.
So I think it more goes into the idea of why let the patient rest with this on when we can just have them do exercises that they wouldn't be able to do prior because of their injury, and really kind of push the envelope in terms of all that. It'd be interesting to see if it just purely alone with the external kind of trauma that it adds can increase blood flow. I'd imagine it would, just because it is sending signals to the brain that something is wrong and is going to cause the brain to respond accordingly.
Mm-hmm.
But I think that almost may take a step back, if you know what I mean.
I agree. It's a passive intervention. You might as well, it's like throwing a heat on it.
Mm-hmm.
And
which, like, okay, keep going.
Go ahead.
Yeah, well, it made me think now if the patient's like very acute or even like inpatient setting, patient can't move too well and is having trouble even moving the leg, then maybe it has its applications there. Just like in terms of patients' current level of function being extremely low, but I think that's a very niche, sort of intense patient population, and that'll be hard to get research with.
I agree. It's hyper acute. And also, the whole point of us as a clinician is to be there to start retraining movement patterns, to make some active intervention, active change. I was just curious if that was something mentioned or not. I don't think it would be of use in a session at home or in a clinic, but I was just curious if you saw anything.
Yeah. No, I haven't read anything like that. It'd be interesting to see if there was any kind of research out there about it, but I feel like it's not going to be very applicable in a broad set.
Okay. So in general, you referenced, most of the studies are lower extremity based. You can use on upper extremities. See a lot of ACL papers, saw a couple NEOA papers. Is there any other pathology you saw that commonly popped up, or was it primarily those two? Anything hip or ankle?
So there was a couple ankle ones. There was actually one about Achilles tendon rupture using BFR, and there was progress made. in conjunction with the general like healing timeline you'll see on ruptures in the ankle. When I was reading about it, there wasn't much. I think it's generally because you don't see a widespread of ankle injuries. I speak to ankle because going more distal is kind of where I'm bringing my focus to, because you can't really occlude the hip because it's a very central joint and where are you going to put the cuff. So in terms of ankle, I think it had the same effects in terms of like what it promoted, cross-sectional area of gastroc and increased load, decreased pain. In terms of elbow and hand and stuff like that, there were more case-based studies. And I think it all has to do with what's the word? It all has to do with the amount of available patients to research on.
Yeah. And
yeah. So yes. And just because like knees are so common, especially in sports, and upper extremity exercises don't require as much load as like a lower extremity exercise would. Mm-hmm. So the structures can almost withstand what kind of dosage you would even give it, as long as you're following the general guidelines for healing. But I do believe it has applications in upper extremity just because of that hormonal influence we see via involved and uninvolved side. So any patient can benefit from doing the upper extremity if they have injuries up top.
Yeah. I've used it a few times for just to try it, because why not? If you have access in class, access in clinic. I mean, the fatigue's crazy. Other thing. So in general, we saw we got some basic guidelines that came from the research that our faculty had done and provided to us, and utilizing it with our exercise applications course. Is there anything else that you guys saw that was super effective besides your 30 to 60% occlusion for upper extremity, 40 to 80 for lower extremity, 30, 15, 15, 15? Or is that still kind of like a standard?
That's almost become a standard, it seems. Quite a few studies I saw went as high as 80% of limb occlusion, which in my personal opinion, I think following a percentage guideline is going to be better than having a general occlusion dosage being like 180 to 260 millimeters mercury, just because it's more applicable to what the patient can withstand. And it also helps with being able to tolerate it. Now, wherever you set up the patient, that's going to really dictate how much they can handle. I do agree with the fact, like, always be above 30% of like 1 rep max in terms of like what kind of load you put externally. And when you have the pressure set, anywhere from like 40 to 80 is going to really give you that general kind of external trauma that we kind of promote with it. I would even say 40 may be a little too low, and I would probably start my patients at 50. Granted, I used it in clinic once or twice, and we had just entered it in our courses because I did it during CE1, didn't do it at all during CE2. So my understanding was pretty robust. So I kind of just stuck to the metrics that they gave me. Didn't really try to explore too much about it. But now that I have the experience I have, which still isn't much, but it's more than back then, I would probably start them a little higher.
Yeah, I only used it once, and it was for a knee OA, actually. Bilateral knee OA. It also in my first rotation, didn't use it in my last rotation. I don't think we had a cuff at that hospital.
Yeah.
So, when you were also in a different setting. Even in my ortho setting, though, for the 2 days a week, there was definitely a few patients I would have used it on. I had a guy who was, I mean, it's not crazy for a post-op knee to have large fluctuations in their early acute phases, strength and pain. As you're educating them on what to do and trying to reintroduce gait, you're going to have changes, especially with swelling. But he probably would have had a significant benefit from using that just as a way to, not that monotony is a problem, but to change up and trial something and see if it had an effect for him. I definitely would have used for that patient and a couple others. It would have been nice. But it was working for my knee OA patient in my first rotation pretty consistently, showing increase in strength, able to start to progress the exercises, not just in load, but in complexity, for a patient who was not seeing any changes on her own for a year, 2 years. So.
Yeah. Which I think that's kind of the thing. Patients, depending on where their baseline was, they'll benefit from almost any kind of generalized treatment you give them. Granted, if their baseline was super low, zero to anything is significant benefit, right? So I think considering that BFR is more of a tool to apply to see if this different kind of therapy works for them is one thing to kind of keep in mind, and not like make it your framework for any kind of therapy. So I think it has its applications in higher level patients, being like athletes and stuff like that, just because their baseline is already so high that general post-op rehab may not be good for them, just because they've already surpassed that physically, and they're going to need some other sort of form of resistance to give them the benefit that they need to get back to where they want to be. So I think that's also kind of what limits BFR in terms of being more generally applied, is that patients will see benefit already from being in therapy. So it's the idea of like, why make it more complex than it needs to be, which is why I think it's not as commonplace as it can be or could be.
Yeah. I do see where in your high level athletes, the risk of atrophy is only going to delay recovery. And if you can minimize that all, and this offers you an opportunity where otherwise you wouldn't be able to, that's where it fits in the post-op phase. We're kind of just thinking earlier before we even started recording, but the further applications, obviously we see it used in the fitness world, but I had thought that it'd be pretty effective, I think, in reducing overall strain for some high level performance athletes as they get ready to deload. Or I've been watching a lot of running stuff because I've been getting into running myself, and there's the tamper down as you go into like the 2 weeks before, and if you want to reduce the overall load and strain on this, could be something that continues to increase your systemic response without having a overly traumatic 7-mile bike, 7-mile run at high resistance. This could be an opportunity to do some exercise that's still going to give you a good systemic response and promote that increased blood flow post and recovery. I'd be curious to see the effects of BFR in recovery. I think that would be a really cool comparison going forward in research. Is what is the recovery timeline for a BFR exercise over 4 weeks, over muscle soreness onset, persistence of that soreness, and compare it to traditional weight training or traditional cardiovascular training and see if there's any differences in the recovery. There might not be. This might just be like me wondering if there's a magic 8 ball. There's no such thing, but it'd be
right.
thing.
Well, that would, I think in my head, I don't think they're very, like, cardiovascular fitness and exercise, I think, are different in terms of what they promote as what BFR promotes. BFR, I think, is more closely related to like weight training and resistance training. So I think it'd be interesting to see if it's applicable to like that sort of like aerobic capacity fitness realm,
There are
because
training parameters for the utilization of BFR.
is there? I don't think I've
There
seen it. Did we learn about it in class?
I read it in one of our handouts, and I can't remember it because it was bilateral lower extremity cardiovascular training parameters for aerobic capacity. It was not exactly the same. Obviously, it's not a rep scheme, but there was a time component to it. I think I was just more curious about physiology, or going back to the physiology with the post training with occlusion and the cascade effect, and the hormonal effect and the increased O2 post, if that had any effect on that soreness recovery.
Yeah, I mean, it'd be interesting to see. I know with the general like resistance parameters, you can actually be very sore post treatment just because of that lactic acid buildup that it kind of promotes.
Which is the goal. You are trying to create a hypoxic
yeah, which is exactly the point. So
I don't know. I'm just thinking out loud.
I'd be interested to see it, just because my narrative review was primarily on ACL rehab research and stuff like that, and limb occlusion at the knee for hypertrophy and like cross-sectional area, not so much aerobic fitness, which, I mean, if it has its place in it, I'd love to see more research about it. But I think that's going to be something that comes down in the future, because we're still trying to get this anchored down for strength training.
Yeah, no, I agree. Is there any other like places where you see, I'm just kind of asking at the wall here because we don't have to stick too much longer on this part, but I was just curious, is there anywhere else you see where this would be effective? I'm just trying to think. I see the post-op where it makes sense. You're trying to reduce overall strain. I could see potential for deloading and tampering down and high-level performance athletes, where you're just trying to reduce the shear, I guess.
Sure. I think it could have its place in terms of dealing with patients with chronic pain. And I say that more with the mindset of like patients with a low pain tolerance. I don't want to call it that, but for lack of a better term, low pain tolerance.
A shifting threshold.
Sure. Yes, that's a very nice way of putting it. With a shift in threshold, to help increase the load without increasing their pain. And as we saw with some of the research that I've went into, it does have a influence on pain and decreasing it. So patients with like chronic pain syndrome and things like that, I think it potentially has a place there in terms of being able to give that patient the most benefit while keeping their pain down and ideally decreasing it. So
I think that'd be that's a fascinating subject. I agree. I didn't even think about that.
Yeah. So I think it's one of those, pain essentially is just like one of those catch-all kind of symptoms we see with almost every patient population, but it also is its own thing that patients come to us with that needs to be addressed, whether that's with like diaphragmatic breathing, low load exercise. BFR can offer those low load exercises while giving a full load response. So I think it's another place that it can be considered when working with patients.
It's also a great opportunity to reintroduce movement for those patients, where you can reframe what movement looks like and can look like, and what load looks like for someone who may be scared to, because they have experienced these abnormal pain responses for so long that it decreases their overall activity because they don't want to be in pain. And then you have that feedback loop. So, reframe it. Yeah, you know what? Maybe starting off with a dumbbell or goblet squat isn't right. We can trial this. It's going to be a much lower load, but it's going to give you some benefit in reducing any atrophy that you've experienced over the last year with this new onset pain. And it may be a way for us to reintegrate moving and exercise and something that isn't painful, and give you a starting platform.
Yeah, exactly.
Inviting them in to reframe how movement can be pain-free.
Right. Yeah. It can be a great educational piece, and I feel like a lot of what you were just describing made me think of like fear avoidance behavior, and sort of like reintegrate a patient's confidence in doing those movement patterns while reaping some benefit from it.
Yeah.
You see what I'm saying?
A greater benefit than you would from just a simple active range of motion exercise.
Yeah, because it's beneficial alone just to do the movement to build some confidence in the patient and their ability and reintegration of those movement patterns. But to place the cuff on would essentially capitalize just a little bit more on their available ranges and what kind of gains we make during that time. So not only are we increasing their confidence in movement patterns, we're also seeing some sort of physiological response now because of the cuff. Now, I say this all with kind of the caveat of like, they're gonna start moving like they didn't move before, so they may have benefit alone. But I think it's basically the difference between like inches, basically taking just a further step in terms of gains than we would. So it's getting the most out of our time with the patient.
Effective use. All right, let's close it off with what are the limits? We talked about some applications. Yeah. What are the limits you guys came up with for the most part?
So some limitations, like we kind of already mentioned, were that the dosing parameters aren't very universal yet. We have a lot of common guidelines that sort of overlap, but it's like the margins are widely spaced. So I think it's more currently that it's up to the clinician's discretion on what they believe is the most beneficial sort of dosing pattern. Our faculty, Mark in particular, has his pattern that he likes. There's a lot of different research articles out there on how they dosed. They all seem to overlap somewhat. And I think being able to find a more concise dosing parameter is just going to make it more applicable for a lot of patients and a lot of clinicians that don't use it currently. And then one other limitation that is kind of easy to denote is the fact that limb occlusion only really works on distal joints, mainly because of the fact that like shoulder and hip, they're way too close to the trunk to occlude, and it doesn't make sense to try to occlude your trunk. That just doesn't even sound safe when it comes out of my mouth. And so
occlude the cervical region.
Yes, we're gonna occlude your neck for 20 minutes. So it just sounds silly. So that's one of the biggest kind of limitations I think is out there, which I don't think they're going to be able to solve that one. At least I'm not going to be the one to solve it.
No.
There are,
Um,
yeah, which to that, there are some articles out there that Mark has talked to me about that they have seen benefit proximal to the occlusion, like very closely to the hip. So it could potentially be used at like those proximal joints, doing like just general exercises that get the joint moving and having the limb occluded, just because blood flow is going to increase in that direction. So it's going to cross that path. And I think that's like kind of the idea that it can be beneficial, but there's not really any research kind of backing it just yet. So that's kind of the one big limitation that is currently on this topic of research. And I believe those are the two big limitations that I had in mind. I don't know if you came up with any as I was chatting about it.
no, I did come up with another application in my head, but just thinking about time constraints. If there's, I want to go back and review it, but if there's the aerobic capacity training one, like that could be an opportunity to shorten, since you're not going to have occlusion for, a long run. If you're going for 18 miles, it takes 3 hours. But if you have time for an occluded aerobic capacity training session that maybe lasts only 20, 30 minutes, I think it's 20 minutes max, you can get some benefit in a shorter amount of time. So that could be an application to some of those athletes. But like super niche, not as important. Couldn't think of much else other than that. Yeah, you can work with the appendicular segments, but getting more proximal is going to be tougher, although there may be some benefit. Okay. Blood flow restriction. Cool. Hope to learn more.
Sweet.
All right. That is today's episode. We will have another episode coming out shortly after this one, which we'll record tomorrow, having on a PT, an actual doctor, and as our first guest. And we'll intro that person when we start that episode. So stay tuned, check it out.
Yeah. Appreciate you guys watching. Please like and subscribe, share our videos, let people know, get our name out there.
Yep.
And that is it, y'all. Thanks for watching.
Take care, y'all.